and Royal College of Surgeons in Ireland. Niamh is a postdoctoral researcher currently working in King's College London. She completed her PhD in 2022, which was about understanding the prenatal origins of mental health problems. Since then, she has been using large surveys of children and teenagers across Ireland to better understand how and why mental health problems begin. Thanks, Niamh.
Thanks, Anne. I'll just share my screen. Okay. I'll just assume everything is presenting as it should, unless anyone says anything otherwise. Okay, so thanks for the introduction, Anne. I'm just going to talk a little bit about population mental health. So some of my PhD work and some of the work I've been doing more recently. Essentially, what I've been doing over the last 5-10 years is trying to understand how mental health problems come about by using large data. So, data sets of thousands or more of people. And generally, I look at longitudinal data sets. So following individuals up from early childhood, sometimes from birth, into their adulthood. So just a little bit my educational background. So I started off in psychology. I then went to kind of the more biological route. I did 2 years of cognitive neuroscience, did my PhD in population mental health, also known as psychiatric epidemiology. And then now I'm trying to take more of a positive and implementation route by being involved in clinical trials. So as you can see on the right, I like to travel. And I do think that research has given me brilliant opportunities to travel. And for those interested, actually, if anyone is interested in traveling as part of your research degree, the Erasmus program will give you funding to do a stint away for each degree that you do, your bachelor, your master's, and so on. So I'm going to talk about two of my research areas of interest today, and those are the prenatal origins of mental health problems and the state of kind of youth mental health in Ireland today. I'm not going to talk about the last one, sex, gender, brain development, and mental health, but you can find some of my publications online. So the reason I'm interested in this, in the prenatal origins of mental health, is I suppose it's where it all begins. And I've always been fascinated with what degree of risk or resilience for mental health problems are you born with at baseline. I know in psychology and in social care, we're often very concerned about adverse childhood experiences and bullying and deprivation. And of course, those things are massive and well replicated risk factors. But to some extent, we can't really understand how those things act on the brain and on vulnerability until we understand what people are coming into life with. And another kind of reason to be quite concerned about the prenatal origins for mental health is that, so classically, I suppose the two most well-known risk factors be premature birth and low birth weight. And the number of people being born with low birth weight and being born preterm has increased incredibly over the last couple of decades. And that's mostly largely due to improved technology and, better medical practices. But it means that we have a bigger group of the population actually reaching, childhood, adolescence, adulthood, who are born low birth weight or preterm. So I'm focusing on birth weight, and I did so for a large degree of my PhD work. And in one way, it's quite a poor measure. It's such a rough proxy for prenatal health. It encapsulates maternal and fetal genetics, and then also whether the mother being quite sick or her nutritional status, infection rates. There's so many things that go into that birth weight. On the other hand, it's widely available. So for someone that's interested in big data like me, it's lots of data sets have it, which is also reflected. And I suppose it's one of the first things you hear when a child is born, isn't it? Their sex and their birth weight. And what I've done is looked at longitudinal data sets where we have birth weight for thousands of young people, and we follow those people up throughout their childhood and adolescence. And here's one of the main findings that came out of this research. So essentially, that there's a dose response association between birth weight and the risk of mental health problems in childhood. So the horizontal axis there is odds ratio. So it's essentially either the risk or the likelihood of poor mental health in, as this would be age 9 or 10. And then the different categories of birth weight on the vertical axis. And one of the things that was, a lot of the research had shown before I did this work was that children born with low birth weight, so under that 2.5 kilogram marker, or preterm birth under the 37 weeks of gestation, they're at risk for mental health problems. But what's come out more so in the last maybe I'd call it the decade of research is that it's a dose response association. So there's a higher risk of mental health issues for every kilogram lost of birth weight. The other thing that came out of this research is that association between lower birth weight and higher rates of mental health issues seems to be strongest for ADHD-like behavior. So these are things like hyperactivity, impulsivity, and inattention in childhood. And the researchers on this call will be thinking about all the potential confounds. So all the things that could explain low birth weight and equally poor mental health. So things like, relative poverty in the home, any number of things, household, any sort of kind of stigmatizing factors in the home, the psychiatric history among the parents. And not only our study, but other studies also find that this association survives correction for those confounding factors. And if that's not enough, a lot of other studies have looked at siblings and twins within households who differ by birth weight. So even in identical twins, there's often differences in their birth weight. And studies have shown that in siblings and twins who differ, whose birth weights differ, that difference in birth weight maps on to differences in their mental health in childhood. So just another kind of support that the association goes beyond the confines like socioeconomic background. So I'm not going to go into each of these papers in too much detail, but essentially these are some of the publications that we produce, and you can read them later if you're interested. But the one on the far left, we found that the association between birth weight and mental health, it seemed there was a gender difference there, and it seemed like actually lower birth weight was a much stronger risk factor for young males than it was for young females. In the second paper, we found that while ADHD related problems were the most strongly related with birth weight, actually there seemed to be an age dependent association with emotional problems. So things like depressive and anxiety problems were related to birth weight, but that association only really manifested towards the end of adolescence and age 17. And in that last paper there on the slide, we looked at different reasons, different contributors to the association between birth weight and mental health. And yes, there was a large chunk of that association, which was explained by the confounds we were just talking about. So familial sociodemographics and parental psychiatric history. But there was also another large chunk of the association explained by things that we know contribute to birth weight, like and maternal drug use, smoking, alcohol use. So you can read more about them if you're interested. One of the other studies that we did, which I wanted to tell you a bit about, was, so all of this, birth weight and mental health is a very observational association. But one of the things that we could use this observational data is to gauge, well, how well can all of this prenatal information be actually used to predict who's more likely to develop ADHD? So what we did was, using a United States data set called the ABCD study, we extracted all of the prenatal and perinatal information within the data. So things like pregnancy complications, delivery complications, maternal age, paternal age at birth, and so on. And we put it into a predictive model, and we looked kind of to see how well it could predict variation in ADHD symptoms by age 9. And it didn't perform that well. It explained about 5 to 10% of the variation in ADHD symptoms. And I suppose to some of you who are interested in kind of postnatal risks like adverse childhood experiences, that might be very obvious, because of course prenatal factors don't act on their own. They're compounded throughout childhood and adolescence by other things. But one of the things I thought was quite interesting was that, so this bar chart on the right, it shows the different level of variation ADHD symptoms explained, but in different groups of people. So we found that we could predict ADHD symptoms in children better when they were from low-income homes or when they're from families with kind of a high degree of parental psychopathology. So Emma Butler, who I think might be on this call actually, she's going to bring this research a bit further on, and she's not only looking at pregnancy complications and different prenatal risk factors, but she's combining this with the sex of the child and also social risk levels. So things that happen throughout the life and, you know, that represent kind of the family's baseline risk level, and looking at how these interact to predict childhood mental health problems. So I thought I'd finish this section on just some of the actions and the implications for policy and mental health services. So first, population level screening for mental health is not very established in any shape or form. But I suppose what this research suggests, that if we do have a screening program for childhood mental health, that some of those early risk factors, the earliest risk factors, should also be included. So things like obstetric complications, maternal drug use during pregnancy, smoking during pregnancy, and birth weight. And this will give us the kind of a better chance at intervening, not just what early intervention can mean anytime in childhood, but the earliest interventions if we have that information from the prenatal period. This is kind of an own goal, but improving the quality and the reach of interventions to reduce smoking, drug use, and alcohol consumption during pregnancy is a necessary action. And third, we need to establish in some cases and improve in other cases the screening programs for anemia, UTI, and other preventable, treatable complications in pregnancy. And I would say that with all of these, I mean, in an ideal world, we'd like these for to be universally applied, but in a world of scant resources, it seems like at least some of the research suggests that these could have maximum impact if they're targeted at families who are already at risk in terms of low income or high familial risk for mental disorder, or any other number of risks that could be targeted. So the second part of this presentation, I'm going to just give a glimpse into the state of adolescent mental health in Ireland today, and I should probably specify Republic of Ireland today. And when I talk about adolescents, I suppose generally I mean 14 to 16. I'm talking about mid-adolescents mostly in this case. And while I know mental health can be such a broad term, in this case, the depressive anxiety symptoms would be the most the common ones in adolescents. So you might have come across some of the worrying trends in teen mental health over the last while. So the top one is about increasing rates of self-harm, that self-harm resulting in hospitalization actually, among young people between 2007 and 2016. So the rates have increased in that time frame by 22%, and that's more in females compared to males. And this is also represented in the press, and that bottom one is about, I suppose, parents being very discontented about the state of teenage mental health care, how difficult it is to get in, and when you do get in, the quality of services. And while all of this is reflective of maybe a worsening picture of teenage mental health, one of the problems with a lot of these, this kind of information, is that it's based on service use. And this really represents the top of the iceberg, the tip of the iceberg when it comes to teenage mental health suffering. You know, young people are likely suffering for months, if not years, before presenting to child and adolescent mental health services, and certainly for a long time before presenting to hospitals. And the other reason, I should say, actually, why this data is somewhat limited is that a lot of the information that we have on teenage mental health comes from pre-COVID, and not just COVID having affected young people disproportionately, but also all the other changes that have happened in the world, the rates of screen use and changes in the technological, I suppose, landscape. So our research objectives are actually quite simple in this project. It's to quantify mental health trends among 15 to 16-year-olds in the community, and that is not on the very severe end who are presenting to services, but self-reported rates of mental health problems in the community since 2020, and also to explore youth and adult reported reasons for this poor mental health among adolescents. So we're trying to get an impression of just basically to quantify what is the current situation and what are some potential reasons for poor mental health today. So the sample, the data that we've actually used to answer these questions is called the Planet Youth Study. So there's kind of two arms to the Planet Youth Study. The first started in the West, in Galway, Mayo, or Scammon in 2018. And it's a repeated cross-sectional survey. So they get 4,000, 5,000 teenagers to complete their survey. And then the next year they do it, they get a whole new group of students from those same ages. And in the Northeast, there's Cavan, Monaghan, North Dublin, and I'm involved with some of the surveys that go on here. So we've kind of came to the game a bit late. We had 4,000 young people fill out a survey in 2021. We've just gotten the data from 2023, and they'll also do the survey in 2025. So they're primarily 15, 16-year-olds who are targeted to fill in this survey. We've included secondary schools, but also youth reach centres, so non-traditional schools. And we kind of got a good sample with opt-out consent. So we got special ethical approval so that most children in the schools would complete the survey unless they decided to opt out. And this is a kind of a simulation of the type of information that we want to produce from this study. So we have 6 counties from the West and the Northeast, and we want to try and graph and plot the rates of various mental health problems from 2018 to 2025, just to get an impression, are things staying the same, are they worsening or improving? So some of these results will be coming out in the next couple of weeks. But just so this is some of the results from the 2021 survey in Cavan, Monaghan and North Dublin. So the sample size is over 4,000. And what we found was over a quarter are reporting their mental health as bad or very bad. So 29% of this sample, when asked kind of an open question of how do you think your mental health is, good, bad, okay, they said bad or very bad. And this is quite a bit higher than other studies that have asked the same question. This is another kind of measure of general mental health, the Strengths and Difficulties Questionnaire. It's, I suppose, a 20-item questionnaire on different types of mental health symptoms. And people get a score from, I think, 0 to 40. And as you can see in the dark bars there, so the top dark bar, the Northern Ireland Youth Mental Health Survey, and then the Growing Up in Ireland studies show the average score on this survey, which is about somewhere between 5 and 10. And from both 2021 and 2023 in our most recent data set in Planet Youth, we're seeing much higher rates of, or much higher average scores on this questionnaire. And the other thing that's quite worrying is rates of lifetime suicide attempt. So people were asked, have you ever attempted suicide? And 11% said yes in the North Dublin, Cavan and Monaghan survey. And this is so a graphical kind of representation of that result in blue compared to other previous studies is showing quite a worrying increase in suicide attempt rates among teenagers. So just to revisit some of those kind of questions we had at the beginning, is mental health deteriorating among teens on a national level? I've put a tentative yes, because while it does seem lots of things are worsening, I suppose from this data alone, we really need to just get a couple of more data points to separate out the effects of, well, is this just a North Dublin, Cavan, Monaghan thing? Or is it a 2021 thing? Because, you know, that was right at the end of the pandemic. Or is it similarly, is it a COVID thing? You know, do things start to normalize the more data we collect post-COVID? And why the deterioration? So in that paper that'll be coming out in the next couple of weeks, we found that COVID-19 and its effect on family relationships, friend relationships, and school experience did seem to be strongly related to poor mental health in these groups. And we also found that there were kind of some demographics within teenagers who were doing much more poorly than others. Females, for instance, were reporting much poor self-reported mental health rates than males, and more than the kind of those cisgenders. So those who described themselves as transgender or non-binary were doing, again, much worse than those who identified as male or female. So the ways we're going to try and tackle some of this why question is with youth engagement and adult engagement. I've actually included a QR code here to a short survey if anyone on the call would like to answer, I think, 2 or 3 questions about possible reasons from your perspective, either if you're a young person, if you know a young person, or if you're an adult who has some involvement with young people, what your opinions are about this. And in terms of the implications then for policy, so regardless of the limitations of our research, you know, yes, we have cross-sectional data, and there's still some things to clear up in terms of the separating effects of COVID and time and geographical location. But from other sources and ours, it's clear that we need to invest in our child and adolescent services more. That's child and adolescent mental health services within the HSE, the NHS, but also beyond that from within mental health, or excuse me, primary care mental health services, the partially government funded charities and school services too. And the other thing we need to do is to invest in intervention research more. So a huge amount, disproportionate amount of research in psychology, psychiatry research is about associations and trying to understand how mental health conditions emerge. And it seems like much less is done on what works, what is effective in treating these conditions, and for whom, for girls, for boys, for non-binary, for trans children, for children with other comorbidities. So there's a big room for improvement there. So I'll finish there. Thank you very much for listening, and I'll leave that QR code up top if anyone would like to answer my short survey. Thank you.
Fantastic, Niamh. That was really interesting. I was taking notes furiously because I have a few questions myself, and I'm sure other people do as well. So some fantastic stuff. And just with the comparison with our own youth mental health survey here in Northern Ireland, I think it was done around 2021. So it was pre-COVID. So and some of the reasons and some of the arguments and the discussions that will come out of your data will be fascinating going forward. But I have to move on. We'll come back to you, Niamh. Thank you. And next we have Dr. Aoife Lane, who's Head of Department of Sport and Health Sciences, lead of the SHE Affiliation Research Group of the Technological University TUS of the Shannon. Dr. Aoife Lane has completed her PhD studies on the public health impact of the Women's Mini Marathon. Aoife has a particular interest in addressing the gender data gap in sports science and health research. Aoife is the chair of the Gaelic Games Sports Science Working Group and a member of Sports Ireland's Research and Participation Subcommittee. And her presentation is entitled Keeping Girls in Sport, Fix the System, Not the Girl. Thank you, Aoife.
Thanks, and I'm just going to get set up here now, and hopefully everything is good to go. And I think my display settings, that should be better now, hopefully. Yeah. Thanks everybody, really nice to be invited along and really enjoyed Niamh's presentation. So today I'm going to talk a little bit about, I suppose essentially dropout in girls, but dropout from sport, but hopefully seeing that there is a probably systemic issue around trying to keep girls involved in sport, and that's kind of my aim of today. So I'm going to go through 4 different things. Number one, a little bit of a, I suppose, a reflection on participation in sport and physical activity, talk a little bit about dropout, spend a bit more time on this concept of a gendered environment, and maybe leave with some action areas at the end of it. So first of all, around sport and physical activity participation, well, look at it's routinely seen that boys are more active than girls in terms of participating in sport and also meeting physical activity guidelines. The CISPA study is, I'm sure, something you're familiar with. It's an all-Ireland survey. It's done, I think this is the 3rd iteration. Again, repeated cross-sectional. We don't have longitudinal data, but it gives us a nice indication of physical activity in the context of gender, disability, social class, and other elements as well. But I'm going to focus on gender, and we still keep finding the same things, that, you know, more boys than girls meet the physical activity guidelines. Females are less active in sport than males. It changes across age as depicted by primary versus post-primary. The gap isn't too bad at primary. In around 80% of our primary school age children are a member of a sport club, which is really good, but it does decrease to 70–60% thereafter into post-primary. Gaelic Games is my background, and I'll probably pepper a good bit of Gaelic Games type type references in this presentation, but Gaelic Games is the most popular sport for young people. I think about 38% play Gaelic football, about 25% hurling. So if you put the two together, even notwithstanding the overlap, they are definitely the most popular team sport. But again, males play more Gaelic games than females. Michael McKay is on the call, and I have been involved in a youth participation study that's looked particularly at young people who play Gaelic games. And we see the same trends that if you look at this data here, the 7 days on the top left-hand corner is those meeting the guidelines. And again, you're in or around 20% meeting the physical activity guidelines. And these are kids who play sport. They're active participants in Gaelic games. And again, you can see it's higher for boys than girls. I missed it on the last slide around the muscle strengthening activity, but it's the same trend in CSPA that, you know, you're meant to do 3 days of muscle strengthening activity per week, included in your 60 minutes on average per day of moderate to vigorous physical activity. And about 48% of boys are hitting that target and about 28% of girls. So we're seeing girls routinely do less physical activity and less muscle strengthening activity through sport than males, which, as I'll come back to later, is problematic in terms of what happens with later sports participation. Also, what we noticed in that CSPA or in our Gaelic Games study is that girls have less developmental opportunities. They don't play as much in those inter-county youth spaces. They don't play as much on their own, which is problematic. And they probably play a little bit less in school settings as well. So that's kind of our context. It's nothing surprising. Boys tend to do more physical activity and play more sport than girls. Next, just to look at drop out and drop off a little bit. So drop out is leaving sport entirely, but what happens a lot is we actually have drop off, where we have young people playing multiple sports and they end up falling into one and sticking with that into adulthood. And that's quite common. That's very natural. And I know in Gaelic Games and in other sports, you very much support kids to play multiple sports when they're young. It's good for them. And despite what literature might suggest sometimes, it doesn't have any impact on their subsequent performance as adults in sport. So I've just did a little review of some literature. Difficult actually to, even in this literature, and I'll come back to this later, you know, girls are underrepresented in terms of the reviews that have been done. But there's been some nice work by Crane and Temple in 2015, and there's been a nice review of team sport by BAC in 2022. But for girls, what are the big things that you know, cause them to drop out from sport? And just bear in mind, dropout is almost 3 times higher in girls and boys. One of the ones is low perceived competence. They don't feel they're good at or good enough at sport. They're struggling with the technical aspect of it. And I think that's very much connected with the enjoyment piece, that they don't enjoy it, they're not good at it, and sort of a self-fulfilling cycle then around those things impacting each other. They do like in sport the notion of developing their skills. They do like the values of integrity and honesty. And, you know, it doesn't mention competitiveness there, but, you know, girls do have that as well. But there is that more broader, holistic sense of participation. They really do like the sense of social connection and engaging with peers, and they like to be challenged and supported. Sometimes I feel we can maybe dumb down sport for girls when they actually do like to develop and be challenged in that, and the literature definitely reaffirms that. And look at, for girls as well, possibly more than boys, other pressures do seem to impact their participation. If it's studies or time due to work, those things tend to take precedence. So just on the drop off piece then, so that's dropout. It is common and we can see the reasons for it, but there is this drop off piece as well that we have to recognize, and we don't maybe overrate the dropout too. This is from our Gaelic Games study, and you see on the first bar that even our young Gaelic Games players, more boys than girls are playing other sports, but still a lot of girls are playing other sports. Which suggests that over time they might fall out of one of them. That tends to be what happens. So again, that's not the worst thing in the world as long as they stay being active. The second bar is around previous participation. And again, more boys than girls have previously participated in other sports. But again, the stats are still high for girls. And girls tend to be a little bit younger when they drop off from other sports. So the multi-sport thing is very real. And I think what this will say is that we really need to work across sports when we want to keep girls active in sport. The big piece I want to talk about today, though, and that's just the context piece, is how does this notion of a gendered environment influence those participation things that we talked about, drop out, drop off that we talked about. And I'm using work here that was developed by Joanne Parsons and Fox and other colleagues around this concept of a gendered environment where there's things pervasive across a young girl's experience in sport that will ultimately impact their engagement. And it's only when you kind of name these and recognize them that you see how many things are against us. So first of all, in the pre-sport environment, we've some good data in Ireland to show that even before girls ever go near sport, their movement, their physical literacy is poorer than boys. So there's that gender thing straight away. You probably see it with, you know, sons and daughters or nieces and nephews or children or friends where we're a little bit more encouraging of boys to move and be vigorous. And all of that ultimately will impact a girl's movement and probably preferences around sport. As well, there's less sporting opportunities for girls. Girls like maybe things like dance and gymnastics, and I assume it's the case across the island. There are less of those clubs. We've lots of Gaelic Games clubs, but we still don't even have the same opportunities for girls as boys in Gaelic Games. Then when girls get into sport, we found that girls are almost a year older when they start playing. So that means already they're behind. They're playing catch up. Then they're playing catch up and they have probably lower qualifications of coaches. They don't get as many playing opportunities in their club, in their school that we spoke about. Their technical development isn't as strong. They don't play as often. They don't have as many match opportunities. So altogether, all of these things are going against them. They don't do as much S&C. They probably don't get the focus on skill development that they need. So all of these things in a girl's experience in sport are going against them around what they need to make sure that they're proficient and that they enjoy sport. And there is good evidence about all of those things that I spoke about. Then if girls get injured, again, what we would find is that girls typically have lower access to physios. The physios they do have access to are less qualified, less experienced. And even working as a female physio in a sport environment is really challenging, you know, and that's the same for lots of the sports science disciplines. So again, you have lots of these things that are accumulating to impact a girl's experience in sport. The research piece, I think of all of the research that's in sports science, only 6% are female-only studies. They'd be from the top 5 sports science journals. And I think overall, if you add all of the participants together, 34% are women. So what we have is we're making decisions, we're designing interventions, we're delivering S&C programs, we're delivering our coaching on research that's been developed on boys. It might be the same. It might end up that there's no difference or there's no quirk in terms of the approach that are needed, but it might not. And the point is here that we don't know enough about sport for girls to make sure that we, I suppose, develop them to the same extent that boys do. Visibility is a big issue. You'll all know this. There is less media coverage. I still think it's down around 10 or 12% around the media coverage that's allocated to women's sport. Yes, we get to see in Gaelic Games, there are ring fence games, but they can often be at funny times. They can often be diverted to different pitches and games and so on. So we have a lot of work to do there. There's some really nice international research that shows that there is a bias towards scheduling for women's events. They're always at the kind of less, I suppose, the less attractive times for spectators and for viewers. And then lastly, in leadership, again, the same thing. On Ireland, you know, the big team sports, your soccer, your rugby, your Gaelic Games, the representation of women in leadership is under 20%. It might all rectify itself because there's new quotas in place that you lose funding. But I think what we have in Gaelic Games and likely in those other big sports is a shrinking woman. You know, the representation in clubs and grassroots might be around 30%, but it decreases concurrently thereafter. So again, in leadership, and that's across the board in coaching and officiating, in executive boards, on county boards, on regional boards, on provincial boards, you have a poor representation of women. And I guess what I found is if women aren't there, the girls tend to be forgotten about, which again feeds into this gendered environment that is ultimately impacting our female players. Just as a snapshot for Gaelic Games, and again, I'm utterly biased, and I'll say that, but I'm also utterly critical. You know, girls do start a year older than boys. It already starts at that stage. They're already playing catch up. And are we intervening? Are we doing more with girls then to help them catch up? I don't think that's the case. We do have some nice things in Gaelic games. We actually have the exact same player and coach pathway for the women's and men's games. But if you critique it and you pull off the hood a little bit, female coaches are poorly represented. They're down at 20%. They're less qualified. They're less experienced. So again, we're already disadvantaging women in that system. We have sex-specific organizations. I could do a whole other talk on integration, and I won't because it will get me exercise. But, you know, we do have a way to go around delivering equality for women in Gaelic games at every level of the organization. And at the elite level, we're probably doing a little bit better than in other places. You know, we do have the GPA who recognize each player equally and look after them equally. But as of now, even though there's been some announcements, female players don't have an expenses protocol. They have less consistent access to S&Cs, to physios, to nutritionists, to psychology. So again, we still have a long way to go around how we support our female athletes. I'm painting a terrible picture of the organization that I love, but I think it's important to challenge it. And despite all that, you know, we've this gendered environment for girls, and we haven't got into the fact that they also have these unbelievable sex-specific considerations to deal with. And I don't think that ever even, you know, barely gets spoken about. And I'll admit myself, even when I'm asking about dropout, I haven't asked enough about, do breasts impact the participation? Does your menstrual cycle? What's it like to go through pregnancy and try and come back? And, you know, we're better internationally, not so good here. Some good studies starting to be developed. But again, I guess my point here is, notwithstanding the fact that the system is maybe challenging for girls, now we have all of these sex-specific considerations that are in front of us as well. And I don't think we're anywhere near adequately dealing with those at the current time. There's more, just so you know. There's also, you know, we've got pelvic health issues. I think up to 80% of women can have UTI issues around leakage and so on. It's probably the hidden one. I think with the menstrual cycle stuff I spoke about earlier, about half of our young players or half of our adult players are, you know, don't have a normal menstrual cycle. They're on a hormonal contraceptive. So, you know, it doesn't even affect everybody. And not all of those girls who have a normal menstrual cycle even experience symptoms, you know, so whereas the pelvic health is probably one that's maybe more common than we think. Again, the strength development piece, I was at a conference in Australia last week. It was a joy. And there was a keynote on strength. And I'm sure you've all heard of the celebrity ligament, the ACL. There was a really nice presentation that linked it back to throughout our lifespan, we're not doing enough strength development, which ultimately is the root cause of ACLs. It's not anything else. It's not to do with our hip shapes or our knee shapes or anything like that. And also girls, just, you know, the ACL rates are up to 8 times higher in female athletes, which is astronomical. It actually hasn't changed in 20 years. It's just we're talking about it more, but we haven't intervened enough on that kind of strength cycle. I suppose just to finish, you know, you paint a challenging picture, but I think it's the more people that kind of are aware of the gendered environment for girls and women in sport, the better, because we have a long way to go to achieve this equality. We need systemic change, and I suppose the ones I tend to use quite a lot are, and I love this picture in the top left-hand corner. It's old, don't worry too much, but it was an Irish Times contribution, keep women out. They should be happy at home, and it's mad that they're up in Dublin enjoying themselves. But I do think we need to let women into our research studies, and we need to be very mindful of that. I like that Niamh highlighted gender on occasion there, and we need to be 50-50, if not 100% women. We have a lot of catch up to do. I think collectively we need to rock the system. It is systemic. It's not one little thing. And I'll challenge my own organization more than anybody. We have said we're going to build one association built on equality. And I think there needs to be systemic change in Gaelic games to deliver upon that. I think, you know, I read a lovely piece once about start your own alphabet, and I saw a couple of names, good colleagues on the list there. We want to set up in Ireland an all-island approach to women in sport research, you know, across all of our higher education institutes. We feel we can do a better job for girls if we do it collectively, and that we don't do little bits and pieces here and there. And that's the bigger picture for me. And every room that you're ever in, and I'm sure you do it already, ask that question, what about the W, what about the women? It's uncomfortable. I sometimes feel awkward, but I will keep asking it because it doesn't seem to be the default in sport settings. Again, I probably very much focus on the big three, your team sports. Just as a really positive note, you know, from a coaching perspective, we can do holistic coaching, we can make coaching challenging and developmental, and we can do things equally. And just as a really nice case study, we coached a group of girls in the exact same way as boys. You know, we used these really good coaches. We did the exact same session, boys and girls separately, and we measured how active they were in those sessions. And remember at the start, in every instance, boys are more active than girls. When we challenged them the exact same way and we did the exact same thing and we didn't dumb it down, we didn't think they weren't good enough, we have flat lines here. You know, actually, more girls and boys met the physical activity guidelines when we adopted that consistent approach. So I think sometimes we, and this is a small study, it's 30 participants, but I think, you know, it's really hard to see this. It's rare that you see these flat lines in physical activity across boys and girls. And it just shows you when you adopted the same approach, really good coaching in this instance, there was no difference. The girls responded brilliantly. They were well able for it. They were challenged and they were equally active in that particular instance. So look, that's me. There are fantastic people on this call that I know that do really good work here and that are very much part of this effort to do a better job for girls. And that is what motivates me. And I suppose the big purpose of today was to show you how systemic and how broad the things are that we need to address. But it was lovely to be here and to present, and thank you for inviting me.
Thank you so much, Aoife, and thank you as well, because I know you're not long off a plane from Australia. I think you were back on Monday evening or something, so thank you for making it today. That was a wonderful presentation. It really strikes a chord with me because I have two nieces who play Gaelic up in Derry, and I have a stepdaughter who plays rugby in Scotland, and the same issues across that you discussed, particularly around structural issues and, you know, opportunities to play and have the same track as their brothers and their nephews and their cousins. I mean, it's not the same, but hopefully we're narrowing the gap, and you're doing fantastic work. Thank you for presenting on that. And next we have Dr. Chloe Brennan. Chloe is from the University of Liverpool, Department of Psychology, and completed her PhD on moral injury and post-traumatic embitterment disorder in armed police officers, health and social care staff employed during the pandemic, and university students. Using a public health model of prevention, Chloe is now interested in prospectively understanding how people make moral decisions and how this can develop into moral injury. And her presentation is entitled COVID-19 occupational moral injury and reactive embitterment. Thanks, Chloe.
Thanks for the intro. Yeah, hopefully you can all see that. And thanks for those two talks. They were fantastic. They're going to be hard to follow. So yeah, great. So like you just heard, I'm Chloe. I'm a lecturer at the University of Liverpool. And today I'm going to be talking about moral injury and post-traumatic embitterment disorder. So these are two kind of mental health problems that you can develop if you've experienced something that violates your moral beliefs. And as I'm going to go on to talk about today, this often happens in the workplace, and especially for certain occupations. So people working in the armed forces, police officers, people working in healthcare, they often see things that are quite difficult to deal with, and they often kind of identify really strongly with their job role. So they feel like it's kind of part of who they are. Okay, so the way that we kind of conceptualize psychological trauma is kind of talking about terrible life events that happen. So usually we talk about life-threatening events or things like rape. So most people think about post-traumatic stress disorder or PTSD when they think about psychological trauma, but this has got quite a narrow definition. So you must have experienced something that was life-threatening, or it could be physical violence or rape. And it's kind of forgetting the moral aspects of trauma. And yet we can see throughout history that people have really struggled when their morals have been violated. So as a species, we've always been involved in some kind of conflict. You've only got to put on the 9 o'clock news to see that. And we've also got evidence when we look back throughout history that people have struggled with this. So if we look back to the Norman conquest in 1066, there's evidence to show that soldiers had certain acts they had to engage in to atone for different sins. So, for example, they might have one act they have to do if they killed one person compared to if they just injured someone. And that was likely a way for them to deal with their moral distress. And if we look back at sacred texts across cultures, religions, and centuries, there is evidence of moral injury. So moral injury is nothing new. It's just that it's only kind of recently starting to be researched, and it's universal. And the reason that it is universal is because we have evolved as a species to be quite pro-social. So even though I've just said we've always been engaged in conflict, we are actually quite pro-social. We kind of want to help each other in our groups, and that is more likely going to help us to survive. So we like to treat people as we've been treated, and when that doesn't happen, that can cause a lot of psychological distress for us. So this is essentially what moral injury is. So it's the psychological distress someone experiences after they've been exposed to an event that violates their beliefs. And we call these morally injurious events in the literature, and they can be broadly divided into two types. So you've got your perpetration-based events, and these are when you've done something that violates your moral code. And then you tend to experience symptoms like guilt and shame after that. And then you've got betrayal-based events. So these are when somebody else has violated your moral beliefs, they've betrayed you in some way, and you tend to feel kind of anger after that. So I like this quote by Steven Pinker. I think it sums it up quite nicely. Moral goodness is what gives each of us the sense that we are worthy human beings. So when we do something that violates our own moral beliefs, we don't feel like we're worthy. And when somebody else does that, we don't feel like they're worthy. So after those events, some people will experience psychological distress. So all of those moral emotions I just talked about, we know it's linked to suicidal ideation. It's linked to a whole host of different mental health disorders. The second mental health condition I want to talk about today is post-traumatic embitterment disorder, or PTSD. And this disorder shares a lot of similarities with moral injury in that it's talking about psychological distress after an event that has violated your moral beliefs, but it is focused on one particular moral belief, and that is the belief in justice. And we are hardwired as a species to be very sensitive to injustice. So I've got a 1-minute video to show you now. Hopefully this works.
France began the fairness test with the capuchin monkey. These small, clever animals are kept in large enclosures, but for the short duration of the test, they're brought into a lab. Each monkey carries out a simple task, and when both get a reward of cucumber, everyone's happy. But watch what happens when the one on the right receives a grape instead.
Grapes are so much better than cucumber, and the one who gets cucumber gets really emotionally upset by the fact that the other one is getting grapes. In chimpanzees, things go actually a little bit further and gets very close to the human sense of fairness, and that the one who gets grapes also gets upset sometimes. And the one who gets grapes sometimes waits till the other one also gets a grape. So they get very close to the human sense of fairness.
So the one that's getting the better reward refuses to take the reward until the other animal is being similarly rewarded with the good stuff.
Yeah, that's in chimpanzees. That has never been found in another animal, but the chimpanzee goes much further in that they care about reward division even if they're on the better end of the scale.
Yeah, you can't blame him, can you? It's not great to get a cucumber instead of a grape. But yeah, as you can see, in primates, they are very sensitive to injustice. They feel a lot of rage when something unjust happens, and we are exactly the same. And the problem with that is we often experience things in the workplace that aren't just. So maybe somebody else got a promotion and you went forward for it as well. There's often a lot of interpersonal conflicts between colleagues or managers. And with healthcare workers during the pandemic, they were seeing a lot of injustice. So they were having to kind of decide who, they were making decisions about who got the scarce resources. They were seeing a lot of inequity, and that can be really, really difficult to deal with. So after injustice, it's very normal to feel quite embittered. And I'm sure a lot of us on this call today can probably kind of identify with that feeling of feeling a bit, bittered when something unjust happens. But for some individuals, this feeling of embitterment intensifies, and it is prolonged and chronic. And they want some kind of justice for what has happened. And if they don't get that, they can start to feel helpless, and it can start to impair their daily functioning. And at that point, they could be considered to have a disorder. So it's worth me just saying at this point that actually moral injury and PTED, they are not in any diagnostic manuals at the moment. And a lot of people in the literature don't think we should pathologise moral injury, because essentially it is somebody struggling after an immoral event. But PTED is described as a disorder. So Linden, who kind of coined the term, argues it should be in the diagnostic manuals. Okay, so the original kind of definition of moral injury originated in the military domain. So a guy called Jonathan Shea coined the term back in the 1990s, and he was seeing people returning from the Vietnam War with moral injury. So a lot of the literature has been dominated in this field. But more recently, we're seeing that actually moral injury occurs across a range of occupations. So I carried out a meta-analysis that I published at the start of this year, and I was interested in any papers that reported on the prevalence of moral injury or PTED in the workplace. And armed forces was still the largest group, but actually there was a lot more studies in healthcare, and this was largely because of the pandemic. People were realising that healthcare workers were struggling with moral injury. So across different occupations, there was healthcare, armed forces, first responders, educators, and people working in child protection services. Across all of those occupations, prevalence of being exposed to a potentially morally injurious event was 67%. So it's pretty high. And I was also able to show that actually people working in healthcare had significantly higher exposure to moral transgressions committed by other people like colleagues or betrayal-based events. So clearly this is not just a military problem. In terms of PTED, there's a lot less out there in general. So there was only 10 out of 88 of the studies that I included that reported the prevalence of PTED. And there were papers kind of in healthcare, education, public sector. The prevalence of PTED across those occupations was 26% using the PTED scale. So that's really high when we compare it to a general population sample where embitterment was around 2.5%. So clearly the workplace is a massive risk factor. So not everybody that is exposed to a morally injurious event will go on to develop symptoms of moral injury and chronic embitterment. So a lot of my research has been trying to identify what the risk factors are that somebody will respond in this way. So I've based a lot of my research on these two models that have been published in the literature. The first is a model of moral injury. The second is a model of PTED. But they're both very similar in that in the first instance, you are exposed to a negative life event or a moral transgression. After that, some people will think, actually, this event is not aligning to my moral values and it's causing some dissonance and conflict. After that, some people will experience those moral emotions, so shame, guilt, bitterness and anger for a more prolonged period. And then if people adopt maladaptive coping strategies to deal with that moral pain, so they ruminate on the issue, they feel unable to forgive themselves or others, or they withdraw from people, they're more likely to experience moral injury and PTED. And in both of these models, there are individual differences in traits that increase or decrease the risk. So if you have high self-esteem, high optimism, and high belief in a just world, which is the idea that what goes around comes around and we tend to get what we deserve in life, then you're less likely to develop moral injury and embitterment. So I carried out some research with 400 health and social care staff just a few months into the pandemic, and I looked at a range of those different factors. So exposure to occupational stresses, self-esteem, optimism, belief in a just world, resilient coping abilities, and also how much somebody considers the immediate and future consequences of their actions. So firstly, in terms of prevalence, over 70% of the healthcare workers were reporting that they were exposed to an event at work that violated their moral beliefs, and around 19% were showing clinically relevant signs of embitterment. So that's around 8 times higher than the general population sample I was talking about earlier. And in terms of the kind of risk and resiliency factors, there were 2 key risk factors that were highly significant. And the first one was exposure to occupational stresses. So because this was during the pandemic, this was things around virus exposure, a lack of PPE. So they were going into work, yet they didn't have adequate PPE, having to make difficult decisions around resources, feeling unable to save patients that they usually could, and then also feeling kind of fear or being separated from their loved ones because of this virus exposure. So that was the biggest risk factor. The working environment is really important. The second biggest risk factor was if somebody had low belief in a just world. So that's what, like I just said, the idea that what goes around comes around, and we all kind of differ in how much we believe in this. So people that didn't believe in a just world were at risk of being exposed to morally injurious events and reporting that they were embittered. Okay, so this was a longitudinal study, and I followed up with the staff 12 months later. In terms of prevalence, the prevalence estimates were pretty much the same, despite the fact that some of those issues that I was talking about, so things like PPE, had largely been resolved at this point. So still over 70% of staff were reporting exposure to morally injurious events, and 20% had clinically relevant signs of embitterment. So essentially, once you become embittered, you tend to stay embittered. And this is supported by other findings in the area. So PTSD is actually notoriously difficult to treat because a lot of people don't want to move on from the event, because by doing so, they feel like they're saying it was okay and they're accepting it, and they're not willing to do that. And so that makes it really difficult to treat. Nobody had really looked at the relationship between moral injury and PTSD at this point in the literature, despite the fact that they clearly show a lot of similarities. Both are talking about psychological distress after an event that's violating your moral beliefs. So I did that with this longitudinal study and found that being exposed to morally injurious events at time 1 predicted PTSD at time 2. And this was through weakening people's belief in a just world, and in particular, their belief in procedural justice. So that is the belief that you tend to experience fair processes and procedures. I also interviewed healthcare workers. So these were people that were scoring above the clinical cutoff for embitterment, and found that a lot of the issues were systemic. So things around funding, resources, staffing. So a lot of staff were talking about, it's all good and well giving us mindfulness as an, giving us these helplines and mindfulness training, but actually you need to deal with the systemic issues. Without more resources, staff, decent rest spaces, this issue isn't going to go away. And like the monkey video showed earlier, a lot of people struggled with inequity, either between staff members, but also for their patients. And this often led to a kind of breakdown in the relationship with the organisation. So a lot of people blamed their managers or just the organisation more widely. And a lot of people were reporting that they felt kind of expendable. So you can see from the quote on the slide that one individual said they just felt like they were a number and they were just filling shifts rather than being cared about as an employee and an employer. There was also a lot of kind of negative work outcomes that was coming out of the interviews. So people were talking about burnout, they were talking about sickness absence, talking about wanting to leave the organisation and obviously take their medical and corporate knowledge along with them. There was also quite a lot of evidence of negative psychological symptoms. So some people were saying they'd been diagnosed with a mental health disorder. Other people were just showing symptoms. So again, from the quote on the slide, one individual said that they used to be outgoing, but now they have to force themselves to go to places that are full of people. And one of the reasons this is so problematic is because social support is a huge kind of protective factor for mental health more widely. And that was coming out of these interviews as well. So what's the implications of having staff that are morally injured and embittered? Well, it's kind of twofold, really. Firstly, you've got the impact on the staff member. It's obviously not very nice to be struggling with your mental health. And, these people possibly do need psychological intervention, and yet it's not really being recognised when you struggle with moral trauma. Without sounding dramatic, it will quite literally kill you. So allostatic load is the kind of wear and tear on the body of being exposed to stress and then your body trying to adapt to that stress. So if people are morally injured and embittered, this is likely going to have an impact on their physical health as well. And then it's also got an impact on the organisation. It's costly for organisations if their staff are burnt out, if they're on sick leave, or if they're leaving the organisation altogether. And also staff members that are embittered are more likely to engage in lengthy legal battles. So I was just talking at a conference on Sunday to the ambulance service, and I was talking about a case between Fleming versus East of England Ambulance Service, which was an employment tribunal. And in the case notes, Fleming had post-traumatic embitterment disorder. So there's still a lot that we don't know about this area. So there's a lot of occupations that are missing from the literature at the moment. This is still quite a new area. And people are now starting to try and develop some sort of treatments to help with moral injury and PTSD, which is great, and we need that. But actually, I think we need to be looking at how can we prevent moral injuries from developing into embitterment in the first place, and even better, people from developing moral injury in the first place. And we need to be looking at really, how do we tackle some of these systemic issues? How can we prevent this? Can we develop some good prevention interventions? And also looking at, what are some of these outcomes? So are we seeing a decline in patient care? We can infer from the literature that that's potentially the case, but we still don't have a lot of evidence at the moment. And that's it from me. So thanks for listening, everyone. And